Good morning, everyone. Thank you for joining us for another meeting of the Committee to Study the Safety of Residents and Employees in Long-Term Care Facilities. Before we get started, I'll read through.
This is Alan.
What's that? Oh, before we get started, I will read through a checklist to ensure that the meeting that we are holding is in compliance with the right to know law. As chair of the Committee to Study the Safety of Residents and Employees in Long-Term Care Facilities, I find that due to the state of emergency declared by the governor as a result of the COVID-19 pandemic and in accordance with the governor's emergency order number 12 pursuant to executive order 2020-04 and extensions, this public body is authorized to meet electronically. Please note that there is no physical location to observe and listen contemporaneously to this meeting, which was authorized by the governor's emergency order. In accordance with the emergency order, I am confirming that we are providing public access to the meeting by telephone with additional access possible by video and other electronic means. We are utilizing Zoom for this electronic meeting. All members of the committee and selected legislative staff have the ability to communicate contemporaneously in this meeting through this platform, and the public has access to contemporaneously watch and or listen to the meeting on Zoom or YouTube and via phone by following the directions and links provided on the General Court website. We have provided public notice of the necessary information for accessing this meeting in the Senate calendar. We are providing a mechanism for the public to alert the public body during the meeting if there are problems with access. If anyone has a problem, please email remotesenate@leg.state.nh.us or call 603-271-3043. In the event the public is unable to access this meeting, it will be adjourned and rescheduled. Please note that all votes taken during this meeting shall be done via roll call vote. Finally, let's start the meeting by taking a roll call attendance. When each member states their presence, please also state where they are and if anyone else is in the room with you during this meeting, which is required under the right to know law. Senator Morgan, that's me, will call the roll. Senator Ward.
I'm in my home and started, and I'm alone in the room.
Thank you, Senator. Representative Stringham.
Yes, this is Representative Stringham. I am in Lincoln, New Hampshire, in an office by myself.
Thank you, Representative. Representative Birch.
This is Representative Birch. I'm in lovely Westmoreland, New Hampshire by myself.
Thank you, Representative. And Representative McMahon.
Good morning. I'm in Windham, New Hampshire at my home and in my office, and my wife may come in or out doing some other business as well during the meeting.
Thank you, Representative. And this is Senator John Morgan. I am in Exeter, New Hampshire with my third grader and kindergartner who will be in and out needing help on virtual school. All right. All right, we all got minutes from the meeting on the 1st. Any questions, comments, edits?
I make a motion that we accept the minutes.
Wonderful,
Second.
thank you, Senator.
I second.
All right, and with that, the motion is on the table. Senator Ward, how do you vote?
Yes.
Representative Stringham.
Yes.
Representative Birch.
Yes.
Representative McMahon.
Yes.
And Senator Morgan is yes. Thank you all for that. Sorry, I have too many things open. Next meeting date, we have a fairly Cam, how is our meeting date on the 15th looking?
So we are working to have Susan Buxton, the ombudsman, and then I'm working to get the commissioner of DHHS. But I haven't been able to nail down her schedule yet.
Okay, great. Thank you for continuing to work on that, and thank you again for doing all the scheduling on this. I just want to recognize you publicly for that. You've really been doing a phenomenal job. with this. So Thursday, the 15th at 8 a.m. is our next meeting date for this committee. We may have one more meeting after that. I think that that's up for discussion. We will have the testimony of 3 folks today, with the ombudsman and the potential for the commissioner. Is there anybody else that we want to hear from that you think would be necessary or important as we're kind of running up against the clock here? No?
I think we have a lot of information to digest into a final report, and we will by the 15th. So
Great.
I would
So-
suggest we cut it off at that point.
I would agree with you. And so I think that that's what our plan will be. And we will compile a report, and on the 15th, we can make the decision of whether or not to meet on the 22nd or the 29th to finalize that report, if that works for everybody.
Yep.
Okay, so we will not schedule a meeting for the 22nd or 29th just yet.
They're both open, just so you know, Senator.
What's that?
They're both should we decide to hold one, they're both
Okay.
open.
Thank you. With that, do we have Commandant Peggy Lebrecq available here with us? Great. And Commandant, thank you very much for joining us this morning, and we're looking forward to hearing what you have to say. And the floor is yours, if my 5-year-old allows.
Good morning. Thank you for inviting me to come and talk to you in regards to this very important issue. As you know, the New Hampshire Veterans Home has had a shortage of LNAs for quite some time, far beyond the pandemic, but certainly we are seeing more shortages as the COVID-19 continues. A lot of our shortages or vacancies are on 2nd and 3rd shift. We have determined that an LNA class in-house may be our best bet to go forward. So we are currently in the stages of developing that as we speak. We have in the past, and we continue to sign sheets for our LNAs that do get hired here for the reimbursement of the cost of those classes once they meet the criteria of having worked here. I didn't know if you wanted me to just go through my report and then you guys can ask questions afterwards, or how would you like me to proceed, Senator?
I think that would be the best way forward.
Okay, great.
Would it be helpful for you to share screen, or not really?
Not really. No,
Okay.
I'm good.
Okay.
Our infection control policies here, we have in place, I think, some great infection control policies. We're very fortunate to have a full-time infection control nurse. She works 40 hours a week for us. We also have a couple of what I would call equipment. It's called the Xenix bug zapping machine that we purchased back in 2018 after a very rough winter with the regular flu. We saw immediate benefits from having that machine going around the building and being utilized by our housekeeping staff to make sure that germs and bugs are zapped as they go along. We also have a Clorox 360 machine. Those are rotating basis around the home, cleaning bathrooms, cleaning common areas. And they are now being used before and after inside visits for residents and their families and loved ones. We go in, disinfect the room, they have their visit, and then we go in and disinfect afterwards. Usually takes about 10 minutes for that to clean. And I will tell you that is saving a huge amount of time for my staff, because normally, as you can imagine, if a staff member has to go down and wash down or wipe down every single thing, it takes quite a lot more time than a 10-minute drying from the Clorox 360 machine. In regards to PPE, we are fortunate to have statewide vendors that we've been able to utilize. We've been also have utilized the state emergency warehouse. We've received gowns, gloves, shields, sanitizer, anything that we've asked for that we knew that they had in stock, we've been able to procure through them as well. Don't get me wrong, we do have some back orders with some of our vendors, but currently we do have all the PPE that we need day by day. All bets are off if we get COVID-19 in-house, which we have been fortunate not to have any residents with COVID-19 from March till now. We do have our own vendor sources that we reach out to if we run into a back order issue with a statewide vendor. We have also access to the federal supply schedule because we are a veterans home. And so with the VA in Manchester, they have reached out to us as well and said, is there anything we can help you procure? So we know that we can use them as well. One instance is we already have our flu vaccines in-house and we are giving them to our residents and staff, and we have clinics that we're going forward doing that. The testing of our staff through the surveillance testing. The DHHS working through public health and the CDC, we follow all their guidelines. They've come in on a regular basis. Again, we started out with the normal, they were doing it every 7 days, and we've now gone to every 10 days. And in the near future, we will be going to 10% of all employees every week with 100% on once a month. 100% of those staff members who will comply with the request to, although we strongly encourage that all of our staff get tested for COVID-19, we cannot at this time mandate that. And I know that one of your other things here was talking about staff and employees in the long-term care. And so it said, suicide, study of suicide in both staff and residents in long-term care. Our residents all have access to social workers on the floor. They also have, we have a chaplain who is here 40 hours a week for any of their, that they need to talk to or talk with. And we also would take them to tele-appointments if they need to talk to somebody. If there's somebody outside of the home that they would like to speak to, we do have access for them to get telehealth for mental health care as well. I will tell you that we are very fortunate to have a geropsych nurse practitioner who is now our director of nurses here, as well as we have a geropsych contract that a counselor comes in on a regular basis to see our residents to make sure that their needs are met. Our employees, of course, are state employees, so they have access to EAP. We encourage them to use that program. As you can imagine, in a long-term care setting, we have a lot of grief, and when our residents pass away, we need to be able to deal with that and process that. So we do offer them, not only do we have services here and, you know, like memorial services to help them go through the grieving process, but we also make sure that they know about the wellness program at the state level that they have access to. And that is my presentation to you. I hope that I've at least touched on any of the questions that you might have, but I'm available to answer any as best I can, or to get back to you if you have a question that I cannot answer.
Thank you very much. Appreciate it. Committee members, any questions? Representative Birch.
Thank you, Mr. Chairman. And thank you, Commandant, for your presentation and your information. I will confess that I'm more familiar with the demographics of residents in our county nursing homes and private and county than the demographics at the VA. Could you tell us a little bit about how many people you're talking about and what percentage of the resident population, for instance, have dementia and issues like that?
Sure. Currently, our budget does support, we can have up to 225 residents. Unfortunately, in January, we had about 175 residents. We stopped admitting when mid-March came. So currently we are down to about 140 residents. They are all 100% veterans, as you know. Approximately 10% are women veterans. They range in age from 60 years old We have 3 gentlemen who are 102. So as you can imagine, we got quite the population diversity. Approximately 100 of them have dementia diagnoses, although approximately 75 require to be behind the secure care doors. And although they have their own neighborhoods that they are able to wander around in, they are either a danger to themselves in that they would wander away and wouldn't realize that maybe it's too cold outside and that they should stay inside. So we do only place the residents who have dementia into the secure care. We want to make sure that they are in the least restrictive setting until they absolutely need to be on the dementia units, of which
Thank
we
you.
have 6. Yep.
Yeah, and if I could follow up,
Sure.
one of the areas we've been concentrating on is the increased isolation that residents have been subjected to and disruption in their ordinary lives within the institution due to COVID. And we're talking about activity folks that don't come into the facilities. We're talking about loved ones that can't touch or hold a person with whom they can best communicate through touch and nonverbal methods. Can you talk a little bit about that impact on your population and whether you think there are measures not being done that could be done to decrease the social isolation and increase what normalcy can be brought back into the lives of the residents?
Sure. At the New Hampshire Veterans Home, we're very fortunate that we have a wonderful recreation therapy department. It's very robust. So from the very beginning, we reached out, we got iPads, we got computers, telephones. So we were doing FaceTime, Skyping. We even we are fortunate again, our facility has an area where you can get right up beside a window and you can view your loved one on the outside. That was in the very beginnings. We immediately started with window visits. We moved on when the phases was opened up to do outside visits. And again, you know, we realized that the no touching it is traumatic for our veterans. But I will tell you that they are probably some of the toughest people around. And, you know, we say to them, we're sorry this is happening to you. And they'll say, we've been through worse. And we know that they have. Again, is it impactful? I think sometimes their ability to hear their loved one through a mask or to be able to communicate, we've taken to buying the masks with the plastic so that they could actually read their loved one's lips or the other staff members' lips. For those who are hard of hearing throughout their lives, they've, as you can imagine, to augment their hearing, they were reading people's lips. And when you put a mask on, you can't do that anymore. So for those veterans that we know has that issue, our staff have been wearing the clear face masks. Again, we've tried to do everything we can to augment that. We do have a lot of internal activities that continue to happen through our recreation department. We've started doing Wacky Wednesdays where we have traveling carts going around and staff being able to dress up in theme just to add a bonus to the day or something to talk about. Religious services happen on a regular basis. Again, we have the chaplain who's here 40 hours a week. So those are still happening. We have maintained their entertainment and their internal activities as best as possible, 6 to 8 things going on each day on different neighborhoods. But again, they are missing their families. But when we first got the go ahead to actually have the outside meetings, I had some family members ask me if they could continue to do the phone and the window visit because it was just too hard to hear. So the spouse on the outside has a hard time hearing as well because they're, as well as the veteran in their 80s, their spouse is in their 80s as well. So we have done everything that we can to augment that as long as we have staff available. The one thing that I saw in the newspaper was what they called, it was a hugging, it was a plastic with the arms in it so that through the plastic, a son could hug his mother that he hadn't hugged in months. I think that's a great idea. I think that that is something that we could certainly work to build. But again, it's really difficult. We even had a daughter who came in on one of the first visits who couldn't contain herself and reached across and gave her father a great big hug. And of course we had to say, you know, you can't do that. And that's very difficult for us as well and my staff to try to manage that. So is there more we can do? I always think anybody who's got a great idea, let's use it and let's see what we can do. From outside visits to window visits to telephone, Skyping, we'll do, if you have a good idea, we'd be happy to run with it.
All right, thank you. Further questions from the committee? Coming on, thank you very much. Oh, Representative Stringham, did you have one? You're muted.
Just a quick question on the staffing shortages. We've heard a lot of testimony on the supplemental money provided through the CARES Act. Is in your view, is money part of the role of staffing shortages, or it's just not enough experienced bodies being available?
I really think it's the experienced bodies being available. You know, we are passively stealing hires from all the local homes, and they're passively stealing from us because we just don't have enough bodies out there that are licensed LNAs, registered nurses, or nurse practitioners. This has been coming, this wave has been coming for a couple of years. My human resource director has done quite an extensive report on that that's been presented to Governor and Council when we go forward asking for the enhancements. But in reality, there's just not enough bodies out there that want to do direct care in a long-term care setting.
Thank you, Kamala. The question I had, you referenced that you have some orders that have are on back order, have yet to be filled. I guess the reason it's important to me to understand what that situation is, you know, as we approach the seasonal transition here and the potential for increased transmission rates and COVID-19 numbers in the state. What are some of those areas where you're having trouble filling right now?
Sure, the rolling face masks. I know that we got a small back order on that, but we do have a good supply in-house, but we're trying to gear up and recognize that the flu's coming. And it hits long-term care facilities harder than others. And so we're trying to get up to the max level that we can actually hold in the building of masks. The other item we had a couple of, I think it was medium-sized gloves. You know, it's funny, you can get the extra small, but the medium and the large is which everybody's using. Those are, you know, not to say we don't have any in-house, because we do. But again, we're trying to gear up and up our inventory to the point where we know we're going to be able to get through a bad month if we get one. So those are a couple of the items, and you know, the small sanitizers, the small bottles. We can get the big gallon bottles, but it's the small bottles that we are having a difficult time getting. Again, not that we don't have any, and we're using the large gallons and filling the smaller gallons, which again is, you know, time and energy for staff, but it's well worth it in the end. We have them all over the building. So. But again, just trying to gear up that. So if we see a back order that lasts for 2 weeks, we get our inventory in, we've already put another order out there just to make sure that we are constantly having the product come in.
All right, thank you. And my final question is admittedly broad and general, but definitely important. Are there legislative or state level programs that you think would be helpful to either you or the industry in general, as we all try to make sure that our state is prepared and geared up, as you say?
I think one of the things that we need to think about currently in long-term care facilities, it's a standard practice that all employees get tested for TB when they come in. And that's been around for years and years and years. And that's a pre-employment kind of thing we do. Are we at the point where we should be having that as a pre-employment thing as well, as a state? Is that something that would be palatable to our employees, or would it be a deterrent? I don't know, but I think that we need to ask that question. Should we be testing employees pre-employment mandatory, as we do with TB?
You had earlier alluded to the fact that there is some resistance to universal testing amongst your employees for COVID. Did I understand that correctly?
Yes, not all participate. We offer it 3 times a day so that we can hit each shift. It's from 6 to 8 in the morning. As the 3rd shift is leaving, 1st shift is coming. It's from like 11 to noon time to pick up more 1st shift. And then we offer it from 2 to 3 or 4 to 5 so that we're hitting 2nd shift. The last really robust, I believe I had at one testing was 102 of my 280 full-time equivalents. So that is always concerning to me. And again, we know that there's a collective bargaining agreement, so we don't want to go awry of that. We're not in the place where we can mandate it.
What is the resistance, I guess, is what I'm trying to understand.
I don't know. Is it, I go around talking about it. It's no big deal. It, feels like you jumped in the water in a pool and forgot to pinch your nose, that kind of sensation. So that people, it's a fear factor. It's the uncomfortableness. But I haven't gotten a really good response back of why they don't want to, other than they don't. So again, I don't want my morale to go down either. So I encourage it. I talk it up. We put it on our announcements. We have it posted all around the building, strongly encouraging them to do it. It's the right thing to do. We want to protect our veterans. They are relying on you to protect them. And that's one way to do it, is to know whether or not you are COVID-19 asymptomatic.
Well, thank you very much. We really appreciate your time.
Oh, thank you. And I just wanted to remind, we do screen everybody for temperature. We do ask them all the questions at every shift as they enter the building. But again, thank you, Senator, for allowing me to talk. And again, if I can help in any way, please let me know.
Thank you so much. Really appreciate it. All right.
Dad?
Yes. I'll help you in 1 second, okay? In between things here. How am I doing, Senator Ward?
You're doing okay. I'm looking forward to hearing what Kathy Gray has to say about the LNA education.
All right, the chair calls Kathy Gray.
Thank you very much for this opportunity. My name is Kathy Gray. I'm the President, CEO, and Administrator of Cedar Crest Center for Children with Disabilities. We are a unique facility, the only of its kind in the state, both by licensure and by the population we serve. But I'm really here representing the Monadnock Region Healthcare Workforce Group. We have been meeting since early in 2016, really, as staffing became more critical in all of the facilities in our region. And we've helped to bring an LPN program to the region and collaborated on a number of projects, including youth education, a healthcare careers camp, and a number of things. What I'd like to talk to you about, first of all, to share some data which may be helpful to you. With the help of New Hampshire Healthcare Association and the sector partnership, we recently had a survey for all long-term care facilities about their vacancies. And, this is within the last 3 weeks that this data was pulled together. So it really is current. So statewide, again, just in the long-term care area, there are 564 LNA or MNA openings. That is a lot of caregivers. It represents just under 23% of the LNAs that these employers have on staff. Similarly, the numbers of vacant positions, or the percent of vacant positions for LPNs and RNs was similar, that the numbers of positions are fewer. So for LPNs, it's 130 open positions, which represents 22.68%. For RNs, it's 137 open positions, representing just about 24.5%. So, that is a lot of positions. And this data is not 100% accurate because many facilities have to resort to bringing in traveling staff, people who come from another state, and my facility currently has one to fill an overnight position. So that's someone who we pay a premium to have on our staff or in our building. Most often, it's the overnight shift that is hardest to fill. And indeed, that's how we're using this individual. So if we took out those travelers, these numbers would be much worse. And you may have experienced travelers in hospitals as well, therapy settings. I mean, it's become quite common. So our numbers of vacant positions, if we took those out of the equation, would be much worse. We have tried to get data through the Board of Nursing, trying to get some sense of how many travelers are in state. It's very hard data to get. We also have been, when we initiated this survey, we tried to get the Hospital Association and Home Care Association to join in, and they do an independent survey a little bit later this fall, and we hope to have data that will represent the bigger picture of the number of caregivers that we are without. In terms of some of the why, I mean, before COVID, and for a long period of time, the low unemployment was a critical reason. We certainly have turned things around just looking at unemployment, but since March we have not been able to have students in buildings, and I know the commandant mentioned an LNA class. My understanding is the only LNA classes that public health is allowing us to do, or if it's all your own staff. So you can't bring people into a facility for their clinical experience. And so that's not introducing people to the hands-on care. Our regional group actually just is finalizing a white paper around the concerns of not having access, not allowing students to have access to our buildings, feeling that this is shortchanging the future caregivers. It's certain simulation labs have helped to allow a nursing student to, to do some procedures, but there is nothing like being engaged directly with a patient and talking with them and having that exchange. We feel that that's a critical part of education, and it's also a critical part of recruiting in nursing facilities. If these students don't get exposed to the environment, then they're less likely to take a position in a nursing facility. The other thing that we've experienced really all along, because the nursing facilities are primarily Medicaid funded, and especially since COVID, there's been less Medicare for the adult facilities. But, the income coming into facilities, it does not meet the cost of care, which translates to not being able to pay the appropriate wage for, for staff coming into our building. And I just got an email yesterday about a facility trying to hire someone at $12 an hour. And that was like a residential assistant or just get the right title here, a ward clerk. And again, different facilities call this as an unlicensed kind of entry into healthcare. So they were starting at, in this case, a lower rate, and, stores down the street were offering $5 more. And there were positions that require no training for up to $28 an hour. So we're really in a tough spot in terms of having wages that are competitive. The other sort of flip side of that is that the costs of care have gone up exponentially during COVID. One example that you were just talking about is PPE and enhanced cleaning protocols and all. And we've all assumed that as a cost of providing care in these times. But also, if you think about the testing, the requirement or, getting your staff to come in when they're not on shift. I know when we had to test all of our staff, I had more than 50 people come in on their day off or before or after their shift to be tested. So obviously that was extra cost, but we also, because of the state's 2-hour rule, we have to pay them for 2 hours, even if the testing, takes 10 minutes. So the cost of testing, and even in the surveillance program where the state is paying for the tests themselves, there are those labor costs that I understand in some of the larger facilities is killing the organizations. The other thing about testing, the concern right now amongst healthcare facilities, nursing facilities, is the transition to sort of privatize the testing. And while they can, and our licensure, we're not a part of this, so I'm not including Cedar Crest, but the nursing facilities can contract with the lab of their choice. But the challenge is, if you're a small facility, you're not going to get a discount, compared to some of the larger facilities or homes that are owned by, multiple homes owned by one owner. And the state is going to, as I understand, is going to pay $100 per test, but the going rate is $175 per test. So again, the facilities have to absorb that from their Medicaid dollars. And in many cases, they have not been able to utilize all of their beds because they don't have the staff to provide the care. So they're not getting the income that they should have in order to cover costs. And I know that especially for some of the privately owned facilities, it's really become a horrible situation in terms of, how far into your reserves can you go? The other, just to comment on a few things that you asked earlier about residents, I can speak as the daughter of a resident of an adult facility. So my mom has been in a facility for a couple of years after a significant fall and brain injury. And, it's been hard for her. And it's been hard for me as previously the primary caregiver. But I think it's been amazing with the restrictions that have been placed on facilities, the kinds of activities in the bedrooms that residents have been offered and engaged in. And, again, it's challenging because the visits, while they're being offered, every resident has to be offered a visit, which means because of staff supervision, there aren't enough staff to have everybody have a weekly visit, for instance. And again, it depends on the size of the facility, but, example, many of my visits were scheduled during the week. There's no way I can leave my healthcare facility, to visit. And, and I've been able to try to work around that sometimes. But all of these, it all goes back to having the staff resources to make it all come together, which really goes to, we need to bring people into facilities to train them. We need to be able to pay competitive wages, and we need to retain our staff and support our staff. I know that, everybody's, really focused on the staff as well as the residents, but it's getting harder and harder. And with the return to school and remote learning and, our staff that need to take time off in order to educate their children, it puts a burden on others. Or if they have to quarantine because of a family situation or their own, the demands on the staff we have are great. And, though it's somewhat of a buzzword, we're talking about COVID fatigue. What can we do to keep everybody going as we're headed toward a fall that's likely to be even more challenging? With that, I'm happy to answer any questions.
Committee members? Senator Ward?
Thank you, Mr. Chair. Kathy, could you tell me how many LNA programs there are available in New Hampshire, and how many students could those programs accommodate under ideal circumstances?
Well, that all shifted before COVID came to be. The Red Cross was a large trainer within New Hampshire, and they, for their own business reasons, and they decided to get out of the training business. And so that hurt a number of areas, including the Monadnock region, where they had been a primary trainer. We have one private agency that is now doing most of the training, and that's LNA Health Careers. And they are working closely with the Board of Nursing and Public Health to try to be able to get into facilities, to have students come for a clinical experience. So that is the one private program. And then the community colleges are getting more involved in LNA training. And I know Manchester Community College has what last I knew was a robust program. River Valley is starting up in the Lebanon area, and we're waiting for them to bring their program to Keene. The other training programs are through high schools, through the career centers. And, you know, I actually don't know the status of career centers right now, but unfortunately, that's a 2-year program. So it takes a long time for those students to complete their work, where an LNA class can be 5 weeks and the person's ready to, you know, to work with supervision. The one bright spot in terms of bringing people into our buildings has been the temporary health partner program. And that was something that was allowed by CMS, Centers for Medicaid and Medicare, and that New Hampshire, a number of weeks later, put the mechanisms in place for that to be allowed in New Hampshire. So in that case, the individual can take an 8-hour online course and then complete competencies in a facility and work as sort of a bridge between an unlicensed staff person and an LNA. There's a lot of things they cannot do, but they are able to provide some care. And being in a college community, we have been able to recruit a number of individuals to that position that we refer to them as residential assistants. They do the 8-hour training and competencies, and they can at least assist in some of the care and take the burden off the nursing assistants.
Follow up?
Please.
Thank you. So my understanding was that, yes, there are these programs, but you have problem having them being allowed to go into a facility where they can actually get the clinical training that they need in order to be able to be licensed LNA. Are there facilities that will allow these students to come in and actually fulfill their clinical requirements?
As far as I know, most of the facilities that have had LNA training programs, they are training their own staff. And I know in one home, they're pulling people from dietary and housekeeping to fill, to be trained and then to work as a nursing assistant. But then there's the problem of you can't recruit to fill those support positions. So it's definitely challenging. But I believe that in the facilities licensed as nursing facilities, the only way they can have students come in at this point is if it's their own staff.
I see. So it's going to be a very difficult situation.
Again, we are advocating as a region for students to be seen as essential, because that's public health is, using that language. Who are the essential individuals besides staff to be in your building? And we believe they are essential. We're going to have a much worse problem down the road if we're not effectively training caregivers. And that's nursing students as well as LNAs and allied health too. And it's come up certainly in the weekly discussion with public health. To some extent, the facility, or in some cases, facilities can make a decision and full transparency, because we're not licensed as a nursing facility and serve a different population with children. We are allowing students in our building. We feel that it's critical. We're ensuring the safety of our residents, and because we're not under that umbrella, we've had the flexibility to cautiously begin to have students.
Mhm. Thank you very much.
You're welcome.
Thank you, Kathy. Representative Birch.
Thank you. And first, I wanted to thank Kathy for the work she does both at Cedar Crest and otherwise as a resident of Westmoreland. I'm quite aware of the good work that's done. I just want to clarify, based on what Senator Ward was asking and what you've talked about, one particular thing in my own mind. It seems like a significant bottleneck is getting students into facilities to do their residency. They are not deemed essential. My question is, where is the place that decision is made? Is that CMS out of DC? Is that Concord? Is that local? Where does that decision get made as to under what conditions a student can go into a facility and cannot go into a facility?
Well, one of the challenges that you allude to is, that we are receiving guidance from CMS, CDC, and public health in New Hampshire. And I myself personally, it's New Hampshire's public health team who have been fabulous. They're helping us interpret the CMS information and to make it our own. It is in the visitation guidance, both from CMS and then from public health, which is continually updated. But it is in that guidance that, when we're in certain phases, we can't have anybody in the building beyond staff. So somebody's brace isn't fitting, you have to decide, is that essential or not? And students aren't on the radar. It has come up recently again as we're, lessening some of the tightness around nursing facilities. And I believe that in a recent meeting, the comment was each facility needs to decide for themselves. So I think there's a growing understanding of the importance of having students in our buildings.
If I could just do a quick follow-up on your last comment, I'm wondering how in real life, how much discretion do you see that nursing home and long-term care facility administrators have in dealing with these directives that come out of Concord or Washington? Does, for instance, at Maplewood, does Catherine Kindop have an ability to vary those directives according to her perception of individual need, or is there really basically no discretion in real life?
I think there's limited discretion, especially for facilities, licensed as nursing facilities. The federal regulations are, 10 inches thick, before COVID, and then to have all of this superimposed. I don't think that, and I haven't really thought through this, but I don't think it's, disciplinary action if you make the judgment to have someone come in or to vary. But if you had a negative consequence, you're out on your own. So, I think that's the challenge. Cedar Crest as a pediatric facility, we early on met with licensing and certification and public health to talk about our unique situation. Number one, in terms of licensure, we're not technically a nursing facility. So all those rules, the COVID current rules, they apply, but they're, again, we're an outsider looking at them, and we're able to make judgments. And then the other part of our conversation with the state folks was around serving children, as opposed to adults. And we just said we could not keep children, including mobile toddlers, in a bedroom, as seniors are needing to do. We just felt that that was a disservice to a 2-year-old, who had mobility, and we have an on-site school. And we said, with the support of our medical director, that, we understand that we're then one cohort, and if we have illness, we're going to need to deal with it as a whole building. But they allowed us to sort of work through that, and so I wanted to get that support, that I wasn't out on a limb making a decision that then would, could come back and negatively impact the organization in particular.
Thank you.
Further questions? Kathy, I'm going to ask the same overly broad question that I did our last presenter. Are there recommendations or suggestions that would you would like us to, this committee, to consider as we put together our findings here in the next couple of weeks?
I really think that the support to nursing facilities, if you really break out the added costs, the challenges, staffing challenges and Medicaid, challenges first, and then look at all the extras. If Cedar Crest had to pay if we were in the surveillance program and we had the cost of the labor costs of the testing every 7 to 10 days, as a standalone 26-bed facility, it would not be long before we could not maintain that. So I think there are hidden costs, so to speak, that that are really challenging all facilities, and that may be bigger than the than your purview. And getting educational programs fully vetted and into facilities. Again, I've heard in the facility where my mom is that it's having students work there, nursing students in particular, that they are able to recruit nurses. And here we are more than half a year without that exposure, and it definitely impacts it impacts the future of the staffing. So that's perhaps one recommendation. And
thank you for that.
Nursing students, we should be training them on the infection prevention and all the things that our staff need to do. So
absolutely, and it sounds like that's something that Senator Ward may be interested in as well. So maybe there's some collaboration we could do there going into another session. Thank you so much. I appreciate your time and your willingness to share the experiences with us. All right, and are we ready for Mr. Blonsky? The chair calls Tom Blonsky, the President CEO of Catholic Charities of New Hampshire. Tom, thanks very much for being willing to join us, and we're looking forward to hearing what you have to say. Tom, I don't know if you're muted still.
We've asked him to unmute on our end, Senator.
Okay, thanks.
Okay, can you hear me now?
Gotcha, thanks.
Great, thank you. Well, good morning, everyone. Thank you for allowing us to speak today. I'd like to thank Senator Morgan for your leadership role in the committee in trying to better understand and get ahead of this issue. So today's presentation will be approximately between 10 to 12 minutes, split between myself, Alan Bernard, our AVP of Healthcare, who will speak briefly, really briefly, about PPE procurement and staffing challenges, and Darlene Underhill, our Director of Clinical Services, who will wrap it up with a brief synopsis of our COVID experience. So Catholic Charities, just to give for context, is a statewide human service organization that also operates 7 nursing facilities, 2 assisted living facilities, and 4 senior independent living apartment complexes around the state. Today, I wanted to start by speaking briefly again from really a 50,000 foot perspective about an industry that has already been in crisis pre-COVID. From a nursing home perspective, we really had an interesting 8 months with a lot of learnings from this past time period. Our immediate job right now, though, is to instill confidence in our residents, staff, and families that everything will be okay moving forward in the event that another outbreak should occur. We also want and are well positioned to be part of the solution as we struggle to grapple with the profound effects of ageism, both in our state and across the country. As a society, we don't value our seniors like we value youth or really even job titles, perhaps. It's as if they have an unwritten expired by date on their foreheads after which they get cast aside and rendered useless. The way we value our frailest seniors is also reflected in the amount of funding we set aside for their care to adequately meet their needs. New Hampshire, for example, is at the bottom of the heap for nursing home funding for our Medicaid residents. I think right now we're number 47 out of 50 states, and we've stagnated there for years. So on average, we lose about $45 per Medicaid resident per day, and are lucky to achieve a 1 to 2% margin in an industry that is already operating in the red and in crisis. So for us, our Medicaid residents represent anywhere between 60 to 82% of our residents, depending on our facility's location, either here in Manchester or as far north as Berlin. We continue to serve our frailest elderlies in our state like we have for the past 75 years because it harkens back to our mission. And yet mission will only take us so far, and without a margin, you slowly begin to die on the vine. And as an industry, this is where we are today. So just as an example, without the CARES Act dollars over the last several months, for example, our initial projected loss for this year was in excess of $5 million. So going back to my initial argument, if we want long-term care reform, it's going to be expensive and require more money. Physical plants are old, they need to be updated or torn down, rebuilt, and rethought. We need more frequent testing, access to good quality and quantities of PPE supplies. And we need better, more sufficient Medicaid rates to be able to pay our staff, our line staff, our nursing staff, who provide the most difficult care and really are operating under the most difficult job in America today. The dignity, we need to offer them the dignity of a livable wage to be able to compete with retailers who offer better wages with less stress and fewer responsibility. So collectively, as a culture, we all have a responsibility to care for our seniors and need to come at this from a place of collaboration where government, communities, and individuals come together to find a solution for sustainable senior care, similar to what we're doing today and what the call of this committee is right now. So I applaud that. So along those lines, long-term care reform needs more thought leaders to offer insightful, creative solutions, not people or media who continue to bash the industry with harmful or biased stories. That's not productive or forward thinking, and it only keeps us stagnant. So off my soapbox there, as an aside, we had a 1.4% death rate. We did have an outbreak at one of our facilities, unfortunately, based on our licensed beds from COVID over the past 7.5 months. And while New Hampshire has had 81% of COVID deaths related to nursing facilities, we closely follow other New England states like Rhode Island at 77%, Connecticut at 72%, and Massachusetts at 64%. Also of note, the average age of our nursing facility residents in New Hampshire is over 3 years greater than the national average, which may call to our higher percentage of deaths because of the higher, not only the higher age, but the higher rate of comorbidities. So Alan is going to speak next just to talk a little bit very briefly about PPE and some of our staffing challenges. I also want to call out Kathy and the Commandant for their comprehensive, very thoughtful overviews of where we are right now. Thank you.
Great. Thank you, Tom. Good morning, everyone. With regards to PPE, currently our facilities have enough PPE to meet the needs of our staff and our residents. Since early summer, the state of New Hampshire has been able to adequately supply our facilities in New Hampshire with PPE if they cannot buy or find it themselves from their normal suppliers. This has made a dramatic difference in our ability to keep staff and residents safe. That wasn't always the case, unfortunately. Back in March and April, while FEMA was confiscating and stockpiling PPE for our national stockpile, nursing facilities were left to fend for themselves and compete with state and national corporations to find PPE. Unless at that time you were willing to buy large quantities and pay inflated prices, PPE was not available to you. Our facilities, fortunately, were able to pool our resources, buy in bulk, and we made a decision, unfortunately, to buy at a higher price than we normally would have in order to have adequate PPE for our staff. And we can probably say that our staff never went in need of PPE, whether it be masks, gowns, goggles, gloves, etc. With regards to staffing, prior to the pandemic, finding enough staff was a challenge. It's not new to the pandemic, particularly LPNAs in our facilities. Unfortunately, it's been compounded since COVID for many reasons, including many staff in our industry have left the industry due to having pre-existing conditions, and also having a person in the household with a pre-existing condition and not wanting to bring anything home to infect them. Also, whenever a staff member currently has a COVID-like symptom, whether they test positive or not, they're required to be out of the building and quarantine for 14, sometimes longer. And then in our facilities, those with more than one job, if they had a full-time job in one building, a part-time job in another building, we required them that they could only work in one building due to the danger of cross-contamination from one building to the other. So that made it more difficult, and we lost some staff as a result. In addition to the negative publicity around deaths in nursing homes nationally, it's made it more difficult to recruit staff. However, we continue to recruit staff and train at the lower levels for our facilities and train unit aides and try to sponsor them to become licensed nursing assistants through our affiliation with LNA Health Careers. As Kathy mentioned earlier, we're not allowed to bring in outside staff, but we can hire staff and train them within our facilities. And that's what we've opted to do. We also offer career paths for LNAs who are interested in moving forward and becoming LPNs, and we'll sponsor them and pay for their LPN program. And I can happily say this year we've graduated 9 LPNs and are in the process of interviewing for the next session in the winter. So we're trying to provide a greater career path than we had in the past. In addition, we're also working with Revere University down in Nashua for their LPN to RN program with their scholarships. Our greatest challenge currently is attracting new staff. It's not training, it's not infection control, it's not providing opportunities for them. It's really alleviating their fears in working in a long-term care facility, given the negativity that's been out there, as Tom mentioned earlier, nationally. Thank you.
Thank you. Good morning.
Morning.
I want to talk a little bit about the New Hampshire experience with COVID and our personal experience with Catholic Charities and the facility that we did have an outbreak in. As Tom and Alan both talked about the death rate in what New Hampshire experienced, it's certainly not a good statistic that 80% of the deaths in New Hampshire were related to nursing homes. However, that figure doesn't tell the whole story. There's a lot more to it. The average age that Tom talked about and the comorbidity certainly is a huge factor. We all know that COVID is more lethal to people who are older and people who have multiple comorbidities. The majority of the deaths and the majority of the COVID outbreaks in nursing homes happened in the early days. If you all remember, it seems so long ago, back in the early days, March, April, was when the Northeast was really in crisis. It was out of control. You had New York, Connecticut, New Jersey, Massachusetts, and of course, Southern New Hampshire is bedroom communities to Massachusetts, and that's where the nursing home outbreaks were primarily, almost all the outbreaks were there. And that's the time that we had our own outbreak in April, early May, at Mount Carmel, one of our facilities. And also at that same time, the two major hospitals in Manchester also were experiencing COVID outbreaks. So it was really a huge, widespread problem. It was in the community, and when it's in the community, your staff lives in the community. They have family in the community. There's really no way to prevent it. The other challenge we all faced was there was no testing at that time. It was pretty much impossible to get testing done for your residents or your staff. We would send people to be tested that were symptomatic, and they were turned away. Nope, they don't qualify. They don't meet the criteria. And of course, Alan spoke about the PPE challenges that we were fortunately able to overcome in our facilities, but many of our peers were making gowns out of shower curtains and tarps, things like that. And we were fortunate not to have to do that, but there were a couple of times when we came within a day or two of having to make that decision that we would have to go that route. But it never did happen, fortunately. But as I said, many of our staff live in Massachusetts, or they cross over, and it was so infected at that time that really impacted the state of New Hampshire. In early May, also right after that, was PPE started to become more available. It lightened up for everybody. The state started to be able to obtain PPE, and they also committed in a remarkable program. I think they were one of the leading states in the nation to commit to testing all residents and all staff for weekly for COVID. That has made a huge difference. If you look at the graph, the numbers started decreasing rapidly at that point in time. My concern right now, one of my concerns is that now, because CMS is only requiring monthly testing, the state is only going to support as far as paying for that kind of testing on a monthly basis every 28 days. And then if we want to test all our staff weekly, it's going to be up to us. And as was mentioned earlier, the testing is very, very expensive. So with the numbers increasing again, that is a concern. The other thing was there was no standard for reporting, so there was no differentiation between COVID cases that originated in a hospital when someone was in the incubation period, but then they were sent to the nursing home before they were symptomatic and no one knew they had COVID, and then they became symptomatic in the nursing home. Well, those cases all counted in the nursing home. There was no differentiation. So the only way the state tracks it is nursing home cases and non-nursing home. So it's really a skewed figure. Our experience at Mount Carmel, it was devastating. We had one, when we did the tracing, the contact tracing, we found out it was related to one staff member who didn't come forward, even though we screened people every day, didn't tell us that he had a sore throat, that little symptom, a sore throat. And we wound up with 37 residents and 18 staff infected. We had 2 direct COVID-related deaths and 2 direct COVID deaths and 4 that were what they call COVID-related. Those were people who were end of life, very end of life, in the final days of life, but because they also had a COVID diagnosis, they were put into that same bucket of COVID deaths. So even that data is a little bit, you have to interpret that a little bit. It really was devastating for our staff. We had staff leave. The morale became very difficult, just that constant being in face shields and all the protective gear and all the stress, and then going home to their families. And the families who had comorbidities, people had to leave. It was emotionally devastating to the residents and staff. And I think it really hit them after the fact, because it was after the whole outbreak was over that we found that staff were experiencing some PTSD symptoms and needed some counseling. And we actually had some managers and some people leave after the fact, after the outbreak was all over. Many people have left the profession, as Alan mentioned earlier. And and the other thing that we were looking at was, you'd see in the media, you'd watch CNN, and you'd see how the hospital staff were being just praised and, hailed as heroes. And then there would be the story about these bad nursing homes, and they had no infection control, and on and on and on, which also is a real morale buster for our staff. So compounded with the fact that we had a challenge before COVID ever happened, attracting new staff, because of reimbursement is a huge part of it. It just made things worse. And the predicament we're in now is just in critical staffing crisis. We are working with LNA Health Careers to do training programs in our facilities. But the problem is we're offering the program, we're advertising the program, we're paying them to take the program and offering to hire people as unit aides. They can come in, take the program. We'll pay them while they're going to school. We can't get people to do it. Nobody wants to do it, because when they can go and I've been looking at ads this week, when you have ads where you can go and, to a retail store and make $16, $7 an hour, $17 an hour, and we're offering $12 and $12.50. People there's no comparison. Licensed nursing assistants is now classified as the most dangerous job in America, and that's been in the media also. So you can imagine how attractive that career path is right now for the wages we can pay. As far as the depression for the residents, as Kathy said, and as the commandant said, we really, our staff was just phenomenal. We did the window visits, the tablet visits, the outdoor visits. We've done all of that. We did have a facility that created a hugging booth, and that's just been our facility in Berlin. And that's just been so remarkable. The residents and the families can actually, put their hands in the plastic gloves through the booth and hug each other. And it's just been a remarkable experience for them. And the staff has just risen to the challenge of doing all kinds of creative activities indoors, finding ways for them to communicate with their families. But certainly it's been difficult for the residents. Now visitation has opened up a little bit. CMS is allowing us to have some indoor visitation. And so we're starting that up, as every other facility is. And we're hoping that, with the numbers ticking up, that we can continue to, keep COVID out of the rest of our facilities. But it is a challenge. And every day, all it takes is one person, one staff member who's asymptomatic to bring it into the building, which is why I strongly support that continuing to test weekly. Because once you identify that person, you can isolate them quickly and keep it out of the rest of the facility. So thank you.
Thanks, Darlene. With that, committee members, are there any questions? Yeah.
Before we move into questions, can Alan and Darlene say their name and their title on the record, just so I have it?
Certainly. My name is Darlene Underhill, and I'm the Director of Clinical Services for the Catholic Charities facilities.
And my name is Alan Bernard, and I am the Assistant Vice President for Healthcare Services at Catholic Charities.
Thank you.
Questions from the committee? None? Okay. I have a small handful of questions here. And the questions will be directed to whomever of the three of you is most appropriate. One of the, we've heard a couple of times from different presenters within the industry about how there have been anecdotal situations of resistance from staff members of getting tested on a regular regimen. Has that been your experience with Catholic Charities places of residence for long-term care?
This is Alan. It really hasn't. Early on, we made a decision to require our staff to be tested. And in a couple of instances where they opted not to be tested, we put them on leave of absence. We felt very strongly that were they not being tested, that they were endangering the safety of our residents. So for about 98% of our staff, they are being tested as needed.
Okay, great. Thank you. And you had mentioned, Darlene, you mentioned a hugging booth up in Berlin. Do you happen to have any pictures of that?
We do, and we can share those with you.
Well, I think that would be really helpful and interesting for the committee. And it was heartwarming to hear how well received that was, and how impactful it was for the residents and their families. And I want to note, Tom, that I did, this committee did, and I did hear you, and it is noted that increased Medicaid rates and the dignity of a livable wage would go a long way in terms of being supportive of our long-term care facilities and the ability to attract and retain staff, and especially in the economic environment that we had before COVID and today as well. So I want to make sure that you know that we hear you, and the staffing situation seems to, you talk about pattern versus event. This is not a single isolated event where we're hearing this. We are hearing this as an established pattern, and that is definitely going to be one of the issue areas that we acknowledge and seek to address in this committee's report. So thank you very much for bringing it forward in absolutely no uncertain terms, and with a lot of clarity. So I appreciate that.
Thank you.
Any additional questions from the committee? Seeing none, Alan, Darlene, and Tom, thank you all very much for being willing to take your time and speak with us this morning. We are very grateful.
Thank you for all you do. Appreciate it.
All right. With that, are we have some time, I believe, right? We're not overtime. We were scheduled for 2 hours today.
Yes, you're fine.
Great. With that, can we see if there are any members of the public who would like to provide any additional testimony or insight or questions?
Do just please virtually raise your hand, and if you're on the phone, you can press *9 to raise your hand.
All right. Seeing none, is there any other business to bring before the committee? And I would accept a motion to adjourn.
I will give a motion to adjourn after I tell you that on the 8th, I can only participate for, no, the 15th, I can only be there for 1 hour because I have gel car at 9. So.
Understood. Well, thank you for the services that the service that you're providing at GelCar, Senator. Important committee, and we will make sure that we get you the exceptional notes that Cam has been taking, the minutes, and if you have any questions,
Okay.
please feel free to reach out.
Okay. Thank you.
This is second. Thank you, Representative Birch. Senator Ward, how do you vote?
Yes.
Representative Birch.
Yes.
Representative Stringham.
Yes.
Representative McMahon.
Yes.
Senator Morgan is a yes. Thank you all very much, and we will see you next week.
Mm-hmm.
Have a good rest of your week and weekend.
Thank you.
Thanks.
Thank you, sir.
Thank you.